Hello, my name is Ian McComb. Tonight we're going to look at the red non-scaly diseases and the differential diagnosis. We've already gone through the red scaly diseases with where the mnemonics, the PM's pet, the little cat called Petal. But today we're going to look at the red non-scaly diseases. And here the mnemonic is "See you later at the Department of Veterans Affairs, EV." Where the C stands for cellulitis, the U for urticaria, the L for lupus, light eruption, or Louis, the old name for syphilis, DVA, D for drugs, V for a viral or bacterial exanthem, and A for an annular erythema. And EV, the first E is erythema multiforme, the V is vasculitis, the second E is erythema nodosum, and the I is an infiltrate. Now you can see there's a large spectrum of diseases here. But the feature of all of these is that there is little or no epidermal involvement. Occasionally, for instance, some drug reactions can present with epidermal involvements, but they'll come under pharmaceutical in the mnemonic there. And sometimes erythema multiforme will cause such a degree of damage at the dermoepidermal junction that there will be some epidermal changes, and there may be a little bit of scale, or more likely some blistering. But essentially, if you look at a rash and it's a red non-scaly rash, the diagnosis should be within this mnemonic. So let's go through these. Oh, a couple of little provisos. I've said there that some scaly diseases, if you've been using strong topical steroids on them, it'll lose the scale. And that'll particularly occur in psoriasis and particularly occur in tinea infections. So if you've got a dermatophyte infection and someone's used strong topical steroids, you may not get much scale there. So you've got to know what someone's been putting on the rash before you definitely say it's a red non-scaly disease. Let's look at C for cellulitis. Clinically, hot red, non-scaly, fixed tender area in the skin. The classic areas are going to be on the cheeks and on the lower legs, particularly the dorsum of the foot or the ankle area. It's due generally to a streptococcal infection. It comes on suddenly, it's painful, there's often fever, it's locally tender. It's a fairly easy diagnosis to in fact make. There are some rarer types of cellulitis, like this hemorrhagic cellulitis that's occurring here in the toe, and this condition, streptococcal perianal cellulitis. This is one that can occur in children. It's not common. They'll present with difficulty trying to defecate, and they'll have this redness around the anus, extending right to the anal opening here. So, cellulitis, hot red, non-scaly, fixed tender area of skin. You can see here just the larger view of that particular image here. I think it's the streptococcal perianal cellulitis. It's worth knowing. So C for cellulitis. What about U? U for urticaria. Now urticaria is a fixed erythema. It comes up in an area for a period of perhaps 4 to 6 hours and then just disappears. It may then come up somewhere else in the body. There are many causes for urticaria. It's due to vascular dilatation and leakage of plasma out of the vessels. That gives you the central pallor area. The redness is just the dilated vessels in the first place, usually due to the release of histamine from mast cells in the skin. Let's just have a look at this this image here. So red non-scaly, often annular, can have figurate patterns like this, usually at a moving edge, and always lasts less than 24 hours. If you've got a rash that's lasting more than 24 hours, it's not urticaria. Often some areas will clear and it'll leave these sort of figurate edges here as well. There are a couple of rarer variants of urticaria, urticarial vasculitis, and papular urticaria due to bite reactions, which are slightly different. This is a type 4 reaction, and it can last more than 24 hours, but it's different from the ordinary urticaria you'll be seeing here. But you can see that they're all red non-scaly rashes here. Sorry, let's slip back. Then, what's the L? See you later. L for lupus, light eruption, or Louise. We've already mentioned discoid lupus in the red scaly diseases. Remember, it's on the face and sun-exposed areas, and the scale can be quite significant. But there are other types of lupus, such as systemic lupus and subacute lupus, and a type called tumid lupus. And also lupus paniculitis, where the lupus, in fact, process involves blood vessels deep in the fat, with destruction to the lobules of the fat. This is a composite picture of some of these different types. You can see these lesions look a bit like urticaria, but the thing is, these will be fixed. These will last several weeks. They won't be varying within a few hours. They won't be itchy like urticaria will be. This is a young child with what's called neonatal lupus. You can see again, it's a red, and you'll take my word that it's a non-scaly eruption occurring in sun-exposed areas. It's because of photosensitizing antibodies that have been passed over from the mother to the child via the placenta. And then when the child goes out in the sun, these photosensitizing antibodies are activated, and this rash will come out in sun-exposed areas. This is the generalized erythema of systemic lupus, again red, non-scaly. And this was an example of polymorphous light eruption. You can see that there's a degree of sun sensitivity here. This is where the strap was, and it's not showing any burning at all. Now you may say this is just sunburn. The thing is, you've got these itchy papules that have come up in the skin as well. And generally this rash comes on, say, 12 to 24 hours after sun exposure, whereas usually a straight sunburn will come on within a few hours. You know you've been burned. But the rash for polymorphous light eruption is delayed somewhat. But again, red, non-scaly. And you just have to, I mean, you might look at this initially and say, is this a form of lupus? And certainly it's one of your differentials. But that's what the mnemonic's there for. So, DVA, see you later at the Department of Veterans Affairs. D for drugs. Now, we've already said drugs can cause a variety of skin rashes. They can virtually mimic any rash on the body at all. So whenever you think of red scaly diseases, you've got to think of drugs, and when you see red non-scaly diseases, you've got to think of them. The thing about a drug reaction and a viral exanthem is that often it's a very florid rash. You know, those large areas of the body are involved. The lesions may itch a little bit. In a viral exanthem, the person's usually a bit ill. They usually have a fever and other features of a virus. With a drug, it's usually the latest drug that someone's been started on, particularly penicillin, for instance, giving this type of rash here. These will all blanch. This is another feature of erythema. You put your finger on it, it blanches. And that's the difference between erythema and vasculitis. If you've got a vasculitis where you've got damage to a blood vessel and blood's released into the skin, it won't blanch. We'll come to that in a little minute. So drug reactions, florid rash of a generalized nature. You can see how florid that is. There isn't any scale associated with that. There's no actual blistering associated with it. Some rashes, drug rashes, may be photolocalized. Look at this. Look at the accentuation in the V of the neck and the lower parts of the arm here. If she flicked her arm out there, you'd probably see that the inside of the arm isn't really involved to any extent. You can see how clear the chest is, the abdomen is, and the lower parts of the chest. And this is where it requires both the drug and exposure to ultraviolet light for the rash to come out. And this is why it's accentuated. These photorashes are particularly seen with, say, thiazide diuretics. They take a while to go when the drug's removed as well. This is the type of rash here that you might get, for instance, with ampicillin, generalized macular eruption. So, drug reactions, florid rashes. Viral exanthems can look very similar. We'll come to that in a little minute or two. Here are some other drug reactions. This is one where there's just a lesion occurring in the dorsum of the penis here. And this is a fixed drug reaction. Some drugs that you take intermittently, not ones you take every day, but ones you might take intermittently. For instance, non-steroidal anti-inflammatories, say for a bad knee or a bad hip, and you take them before the golf. Then it may be that you'll get a rash, and it'll only come up in one area. And that's the curious thing about fixed drug reactions. After a wee while, you may get several areas coming up. Here you've got one where there's been 2 lesions occurring in the dorsum of the elbows here. When they resolve, they leave a bit of hyperpigmentation. Next time the person takes that drug, a month or so later, bang, these areas will flare up again. There might be another couple of little areas that will come. Here was a rash here. It's primarily, I've said, red and non-scaly. You'll look at that and you'll say, oh, there has to be a bit of scale there, surely. I'd have to agree with you just looking at that at the moment. The drug may have caused sufficient damage at the dermoepidermal junction that it gives rise to a little bit of scaling like this. Here you can see, though, same drug and a different part of the body, and it's not giving that fine little bit of scale. It just depends on how much reactivity is occurring at the dermoepidermal junction. So, see you later. We've done cellulitis, urticaria, lupus, light eruptions, Louise. We've done drugs, DVA, virus, viral infections. You can see these can be quite florid as well. Now, they can have a variety of morphologies, but they're usually macular or maculopapular. In other words, they're red and non-scaly. Generally, the patient has a fever, a little bit of lymphadenopathy, and they feel ill. Most drug reactions, patients don't feel so ill. Sure, there are some serious drug reactions like Stevens-Johnson syndrome and toxic epidermal necrolysis, where the patient certainly is ill. But in general, when someone has a drug reaction, you look at how florid the rash is, but they're not ill with it. Now, let's look at viruses. Just bring this one up here. Perhaps we won't. What we're seeing here is a very generalized rash as well. Maculopapular here. In other words, it's raised slightly, but it's a generalized rash, and this could just as easily be a drug reaction. Here we had a viral exanthem, but it was localized to an area of sun exposure. In other words, it came out mainly in areas of sun damage. But this lady was febrile, had lymphadenopathy as well. You can't really see this at this level, but these are little target lesions that may be seen in certain drug reactions as well. But again, red and non-scaly. So it always comes into your differential. Then A, DVA, A for annular erythemas. Now we looked at erythema annularis centrifugum, the one with the little trailing scale, when we looked at the red scaly diseases. Well, there are different types of annular erythemas. This one is again another version of EAC, but there may be no scale associated with it. Some types of erythema annularis centrifugum don't have that trailing scale, and they begin as circles like this. The circles enlarge, and then they join up and start to form these unusual sort of circinate shapes. And this can last for 2 to 4 weeks, and then the rash may disappear. The causes, it can be a drug reaction, it can be viral infection in some people, it can be a chemical, food additive, can be associated with an underlying malignancy in some cases. But in many cases of EAC, we really just don't know the cause. It just comes and goes. It can sometimes even be a fungal infection elsewhere. This is a rare type of annular erythema called the Erythema gyratum repens. And look at these rings here, like the rings on a tree. This is a paraneoplastic phenomenon. In other words, you only get this if you've got some severe underlying disease, and generally it's either a leukemia, or perhaps lung cancer or something like that. So you don't really ever want to see that in a patient. Here is a condition called erythema chronica migrans. Now, this occurs usually after a tick bite, and the tick's bitten in the center here, and then there's the spreading erythema. There's no clearing here. There's no definite edge. There's no scale. But it's quite a common picture after certain tick bite reactions. And it's particularly a problem in the United States and some parts of Germany, where after tick bite you may get a condition called Lyme disease. This is the rash you'll get initially, and then the Borrelia organism can get into the heart, get into the joints, sometimes get into the brain, and cause all sorts of problems. This is a rare type of annular erythema called erythema marginatum, and it used to be seen after rheumatic fever from a strep infection. We really just don't see that much nowadays at all. So, annular erythemas: erythema annularis centrifugum, erythema gyratum repens, erythema chronicum migrans, and erythema marginatum. So we've done see you later at the Department of Veterans Affairs, and then EV. The first E is for erythema multiforme. Now, this is an interesting rash. The classic feature of it is the target or bullseye lesion. Let's see if this one will enlarge for us. There we go. Here's on someone's abdomen, and you can see by a target lesion we mean this dark central area and the lighter pink outside area. Sometimes that dark central area is hemorrhagic, in other words it won't blanch. Sometimes it's even blistering. They particularly get these acrally. By that I mean on the palms of the hands and the soles of the feet. You can see this lesion here, where the damage at the dermoperidermal junction in the center here is so great that that's threatening to come up as a blister. Often in erythema multiforme you'll get lesions on the lips as well, and sometimes on mucosa and the inside of the mouth, and sometimes on genital mucosa. But the latter is more likely to occur if it's a severe drug reaction and presenting as erythema multiforme. And that goes under the name of the Stevens-Johnson syndrome. And it can affect the lips, it can affect the eyes, it can affect the genital epithelium. And they'll usually have some target lesions like this as well. The commonest cause of erythema multiforme, by the way, is secondary to a herpes virus infection. You have the herpes virus, it can be genital herpes, it can be just primary oral herpes, recurrent oral herpes. But 7 to 10 days after the herpetic attack, bang, out comes these lesions of erythema multiforme. And once this starts, it may occur every time you get a little herpes virus infection. So it's one reason to use acyclovir or valcyclovir to suppress the herpes, to stop this erythema multiforme coming up. So the target lesion of erythema multiforme. They may only have a few target lesions, you know, and the other areas will just be erythematous patches or plaques. So that's the first E of EV. What does the V stand for? V stands for vasculitis. And this is where there's significant damage to blood vessels such that they leak red blood cells. And the vasculitic rash does not blanch with pressure. You know, all the erythemas will blanch. The erythema multiforme, the drug erythema, the viral erythema, they'll all blanch. But a vasculitis won't blanch with pressure. And it may be purpuric or bruised-like. Generally, it's the acral areas of the body, you know, the ankles, that tend to show, and the buttocks and areas like that, that tend to show features of a vasculitis first. Simply because most cases are due to immune complexes in the blood that get trapped in the very small blood vessels. And blood flow is often slowest in the veins at the bottom of the leg. And so the immune complexes get trapped in the very small postcapillary venules there, and they cause damage to the wall of the venule, leaking blood. And these are the pictures that you see. These would not blanch. They can be slightly raised. That's called palpable purpura, and it's a highlight feature of vasculitis. Now, vasculitis itself can be due to a variety of things. It can be a drug reaction, it can be due to viral infections, can be due to underlying blood disorders where you have abnormal immunoglobulins. It can be due to certain collagen diseases or even underlying malignancy sometimes. So there's a variety of causes of vasculitis, and there's many tests have to be done investigating it. The bigger the vessels that are involved, the more damage occurs to the skin, and so sometimes you'll actually get ulcers, little ulcers like that occurring in the skin because of the larger vessel damage. Remember that sometimes vasculitis doesn't just, well, in a lot of cases, vasculitis doesn't just involve the skin. It can involve blood vessels anywhere. So you always check the urine to see if there's any blood there. If there is, it means the kidneys are involved as well. And if that's the case, there may be involvement of the heart, the joints, the lungs. So you've got to take those sort of patients, look at them very carefully and watch for damage to these other organs. So that's VEV. We've done erythema multiforme, we've done vasculitis. The other E is erythema nodosum. Now this is a very classic picture as well. It's a painful nodule that occurs acrally, usually on the front of the shins. And that nodule, if we come to it, is often slightly painful and may show slight bruising because the damage here is in blood vessels deep in the fat layer. And erythema nodosum, it's in the septum, it's in between the lobules of fat. That's where the blood vessels run. That's where immune complexes have got deposited. That's where there's then damage to the fat and release of a little bit of blood that gives the bruising afterwards. Erythema nodosum often occurs in women who come off the contraceptive pill. It can occur also if you've got an underlying condition called sarcoidosis. It can occur after streptococcal throat infections. And one of the commonest causes worldwide is, in fact, in the treatment of leprosy, where once you give drugs to treat lepromatous leprosy and you kill off a whole lot of organisms quickly, these organisms plus immunoglobulins in the blood can suddenly block a whole series of small blood vessels in the skin and give rise to extensive erythema nodosum, not just in the lower legs, but sometimes in the arms and the like here too. And these will be tender, painful nodules with a little bit of bruising around them. But as I say, in Australia, it's women coming off the pill, post-streptococcal throat infections, or they may have underlying sarcoidosis. And you've got to do lung x-rays and check them for any evidence of that condition. And the last thing we want, so EV, EVEI, the other I is for infiltrates. There's a lot of things can infiltrate the skin. It can be cells, it can be substances, and it can be infected organisms. So there are a large number of diseases that are actually of infiltrative histology. But there are some classic ones. And I want just to show you some pictures of some of these today. This is a condition called sarcoidosis. It's often slightly more purple than this. These are infiltrates in the skin. You'll feel this and you'll feel these papules under the skin here. There won't be any surface scale. It's difficult to make this diagnosis without doing a biopsy. Sometimes on the face and the forehead, sarcoidal granulomas occur as circles, as annular lesions, but not always. This is a condition called Urticaria pigmentosa, and the skin, you can see it's red, it's smooth. The skin's infiltrated here by mast cells. These are little cells that usually sit around blood vessels in the skin, and they release histamine. But you can get little tumors of them. Children can be born with them or develop them in the first few months of life. And paradoxically, they hang around until they're about 5 or 6 years of age, then gradually just disappear by the age of 10. If you rub them, they'll release histamine and it'll become raised and itchy, like a Hyvie lesion. This is a condition that's red. It's actually non-scaly, but it's a histiocytosis. Histiocytes are abnormal cells in the bone marrow and blood that infiltrate into the skin and can cause damage to the skin and breakdown and ulceration as well. It's a rare disorder, histiocytosis. There are little cells called Langerhans cells that sit in the epidermis. that can sometimes form tumors. These cells usually process antigen on the skin surface or infected organisms or the like and take it to the lymphocytes in the lymph nodes to help start off the immune reaction. And this is another common infiltrative disorder. You know, there's no scale here. There's many lesions. And this is a condition called granuloma annulare. Again, we don't know the underlying cause of this disorder. There's abnormal collagen in the dermis. Cells come in to try and eat up that collagen, but can't. More cells come in and the lesions just enlarge like this. There's no really great treatment for granuloma annulare except intralesional steroids here to suppress this, but often it'll just disappear itself. And there are other different forms of granuloma annulare. There's a generalized papular type as well. But again, it's red, non-scaly. And the only way to diagnose it with certainty is with a little punch biopsy. So infiltrates, it's difficult to make a clinical diagnosis. You often have to do biopsies, and the pathologist helps you to make the diagnosis. So you can see there's a large range of disorders in this group of red non-scaly diseases. It's important to use the mnemonic because it makes your brain think when you're looking at lesions. You know, could it be lupus? Could it be a drug reaction? Could it be a viral exanthem? Is it erythema multiforme? Is it some other infiltrative disorder that the patient has? You won't really think of those disorders unless you use the mnemonic to work your way through the diagnostic possibilities. So, see you later at the Department of Veteran Affairs, Evie, for the red non-scaly diseases. Thank you very much.